Good evening and welcome. My name is Susan Coleman. I'm a trustee at Mount Sinai Health Center and a board member of the Raquel and Jaime Galinsky Department of Obstetrics, Gynecology, and Reproductive Science. Well, that's a mouthful. It's a very important department. Today is a special day. I can't go further without making sure that everybody voted. And good luck to all those candidates out there. We're very grateful that you took the time to join us tonight during this important conversation that we're about to have. While we can't see each other, please know that behind the scenes, joining us tonight are a group of very committed reproductive health care activists and people, just ordinary people interested in reproductive health care. We have some significant updates since our February webinar earlier this year. Obviously, there's been a change with the SCOTUS overturning of Roe versus Wade, which people refer to as the Dobbs decision. That has affected our doctors, our patients, and all of us as women. We will hear further about our philanthropic care fund, which was established this year to help offset the costs of healthcare for women coming to Mount Sinai for vital abortion care, especially those who live in states hostile to abortion rights. I'm very proud of what we're doing on this front. Mount Sinai has long been a leader in the field of complex family planning, and we're fortunate to have three incredible women's health leaders with us today, along with a current student who represents the future of medicine. Because while we're spending a lot of time and energy on reproductive health care, we're also spending a lot of time and energy training the next generation. So I'm very proud to introduce our moderator for this evening's webinar, and that's Alexis Zackham. She's an MD candidate at the Icahn School of Medicine at Mount Sinai. Alexis?
Hi there. Thank you so much, Susan. It's truly an honor to be here with you all this evening to help lead this really important conversation on reproductive health care. My name is Alexis Zackham, and I'm a third-year medical student at the Icahn School of Medicine at Mount Sinai, and I'm the former chapter president of Medical Students for Choice, where I had the pleasure of working closely with Dr. Adam Jacobs and Dr. Monica Dragoman. The purpose of tonight's webinar is to update our community on the Division of Complex Family Planning's work since the Supreme Court overturned Roe v. Wade in June, and to discuss the implications on patients and providers right now and in the months and years ahead. I encourage guests to submit questions during this event, and I will do my best to ask the panelists your questions during our conversation. It is now my pleasure to introduce the very esteemed group of panelists. First, let me introduce Dr. Joanne Stone. We are privileged to have Dr. Stone with us this evening. She is the Health System Chair of the Raquel and Jaime Galinsky Department of Obstetrics, Gynecology, and Reproductive Science for the Icahn School of Medicine at Mount Sinai and the Mount Sinai Health System. She has a visionary goal for this department to become the top provider of comprehensive women's healthcare in the tri-state area. Welcome, Dr. Stone. Next up is Dr. Adam Jacobs, Medical Director of the Division of Complex Family Planning and Associate Professor at the Icahn School of Medicine at Mount Sinai in the departments of Obstetrics, Gynecology and Reproductive Science, Pediatrics, and Medical Education. In the last 7 years, Dr. Jacobs has trained more than 100 residents, fellows, and medical students, including myself, and attendings nationally and internationally in family planning. Dr. Jacobs has won both the Council on Resident Education in Obstetrics and Gynecology and the Association of Professors in Gynecology and Obstetrics Awards for his mentoring of residents and medical students in family planning. I'm also thrilled to introduce Dr. Monica Dragoman, System Chair of the Division of Complex Family Planning, Director of the Complex Family Planning Fellowship Program, as well as Assistant Professor at the Icahn School of Medicine at Mount Sinai in the Department of Obstetrics, Gynecology, and Reproductive Science. Dr. Dragoman joined the faculty in 2020. Previously, she served in medical leadership at Planned Parenthood of New York City and Greater New York, and established the the Division of Family Planning at the Montefiore Medical Center in the Bronx. So I'd like to kick off this discussion by asking Dr. Dragoman a question to define complex family planning and to overview the history of Mount Sinai's Division of Complex Family Planning.
Forgive me, forgot my mute button. Alexis, thanks for kicking us off. I have to say before I dive in, what a pleasure and honor it is to be with you, my esteemed colleagues, Susan Coleman, for this really exciting and important conversation. To start off, I really just want to share how very proud I am to be functioning in this role and directing our incredible team that comprises the Complex Family Planning Division across the Mount Sinai Health System. And as you mentioned, Alexis, I think this terminology may not be familiar to a lot of folks, so I will take a minute to describe a little bit more about what we actually do. So complex family planning specialists focus on treating people who are at risk for pregnancy or have pregnancies that are abnormal, unintended, and or unwanted, and frequently present with other health and potentially life-threatening medical conditions. In essence, we are specialist providers of medical and procedural abortion care and pregnancy loss management who also attend to people's complex contraceptive needs. Our subspecialists can safely provide routine care for healthy women and pregnant people, but so do lots of other healthcare providers, including generalist OBGYNs, family medicine providers, physicians, physician assistants, nurse practitioners, midwives. What distinguishes us as subspecialists is that we have the know-how to manage medically or surgically complex situations that demand skillful evaluation and the full thrust of hospital-based resources. Our expertise ensures that we can help everyone, especially those who require care for anything that is anything but routine. So while the American Board of Obstetricians and Gynecologists officially designated complex family planning as new subspecialty in 2020, a major milestone for our professional community, our department's been home to a division of complex family planning since 2007 and established a specialty training program for fellowship training in 2014. An incredible testament to how Mount Sinai is well ahead of the curve in terms of valuing and investing in this type of expertise for our healthcare community. Notably, our faculty model and teach evidence-based practices and are nationally recognized for clinical excellence and dedication to medical education. And our obstetrics and gynecology residency program has formally trained more than 250 residents during their dedicated family planning rotations, making our program one of the country's largest resident training sites. And as I mentioned, Mount Sinai is home to one of only 28 accredited complex family planning fellowships based at premier academic institutions across the US, something that we are really, really very proud of. Our leadership and dedication to training the next generation of expert reproductive health leaders is more important than ever, especially in the midst of the shifting regulatory landscape where not only patients are unable to access essential health services, but the future workforce is deprived of essential and necessary training.
Thank you so much, Dr. Dragoman. I'm always so impressed by the amazing work that you and your team accomplish. I'd now like to ask Dr. Stone a question to provide her insights as the chair of the Department of OBGYN. So Dr. Stone, how does this division benefit from being a part of the Mount Sinai Health System?
Well, first of all, thank you, Alexis, for moderating this, and I thank all my colleagues and Susan Coleman for being part of this important webinar. It's such an honor for us to be assistant chair of the Raquel and Jaime Galinsky Department of Obstetrics, Gynecology, and Reproductive Science for Icahn School of Medicine Healthcare System. I am incredibly proud of our department. I think we have the greatest department and beyond the tri-state area. And I think that in the realm of family planning, the unique aspect that we bring is that we take care of the most complicated cases. So within the health system and the different hospitals, we benefit from the expertise of our colleagues, our anesthesiologists who help us to take care of complicated patients. The patients that we're seeing that are coming in are truly beyond sort of the scope of the typical patients that need general abortion services. We get the most complicated patients. We have the benefit of interventional radiologists, of general surgeons who really collaborate with us to take the best care of our patients. I think the other thing is that this division has, as you've heard, has a very long-standing commitment to the care of providing family planning services for decades. And I think that that we have a reputation for being a leader in this field. We get referrals even before the unfortunate overturning of Roe v. Wade. We would get referrals in from all over the place to take care of the most complicated patients. And we also have great partnerships with outside organizations. And these partnerships have become incredibly important because these are partnerships with organizations that help us with providing housing services for patients that need to travel in, or escort services to be there and when somebody's traveling by themselves and need our services. So I think those partnerships are incredibly important. I think also I'm super proud of our department and this division for establishing this philanthropic care fund, whose sole purpose is to provide care for patients who have to travel, who don't have the financial means to attain the absolute vital services that they need. And so through the generosity of our grateful patients and interested colleagues and friends, we've been able to raise a good amount of money to help these people. And it's been the commitment of the physicians and all the other staff and the Mount Sinai Hospital in general to reduce the fees so that the amount of money is minimal compared to what they might need in other places. So the care fund is really helping to these patients to be able to travel. I'm sure you'll hear more about that in the future. And then I just want to highlight one more issue. Several months ago, Governor Hochul had come out with a proposal that we can submit for grants in the realm of taking care of patients who require reproductive services. And we were, this incredible team that you see, Adam Jacobs, Monica Dragman, and the other complex family members came up with 4 different grants at Mount Sinai, through Mount Sinai Hospital, Mount Sinai West, Mount Sinai Beth Israel, and Mount Sinai South Nassau, and all 4 were awarded grants. So it's just an incredible testament to the reputation that we have in this realm. So I hope that answers your question, Alexis, and thank you for the opportunity to talk.
Yes, definitely. Thank you, Dr. Stone. Your leadership in general, but especially from the perspective of a young woman entering this field, is truly an inspiration. And I feel so lucky to be training in a department with your oversight. And I mean, all of you, having you all as mentors I'm just in awe that I'm here. But I'd now like to turn it to Dr. Jacobs, who's providing services on the floors of Mount Sinai Hospital. Dr. Jacobs, could you please explain what we are seeing on the ground? How frequently are we seeing out-of-state care seekers?
Certainly. And hi, Alexis. Thank you for moderating, and thank you for everybody joining us tonight. What I want to sort of go over is a little bit of what is happening nationally before I sort of focus on what's going on in New York State and at Mount Sinai. So I'm going to ask the AV team if they can throw up a slide for me right now, which I'm going to then sort of go over with the audience here. And I think it's a really captivating slide. This is a slide from the Guttmacher Institute. And this has been actually updated through November 6th. It's listed here as October 21st, but this is 24th. But this is the current state of where we are of abortion services in the United States. And you can see it's color coded with the maroon being the most restrictive, the orange being the very restrictive, the lighter orange restrictive, all the way down to yellow. And then you start to get into the blues of protective states. And what we have right now is the current state is you have 12 states that are maroon, but basically at this point have no abortion services at all, or providing 0 abortion services. You have 2 orange states, Arizona, which has no clinics in it right now and is providing no abortions. Georgia is a fetal heartbeat law at 6 weeks, so it's only going up to 6 weeks. And Wisconsin, which is in the sort of lighter orange, due to legislative issues, is not providing any abortions. So when you add those sort of states together, you now have at this point 15 states in the United States that are not providing abortions, with Georgia providing only up to 6 weeks. And looking around this map here again, you can sort of see how in the lighter orange states, these are the states that could likely ultimately fall and end up turning into maroon, and ultimately get where you start to have now what could be the concern of 26 states that ultimately in the United States. And you see the states that are ultimately in blue here, which are sort of bordering these states. And I'm going to go over a little bit of some statistics that came out, which are seeing what the impact are on these blue states or these protective states. And just to sort of throw out today's election, how important it is, you can see you have 2 sort of light orange states, Pennsylvania, North Carolina. And these are just a few that are on today's, election that could have significance. North Carolina right now is light orange. And if their state legislature, flips and ultimately they can get a supermajority, they will override their governor and then ultimately most likely become maroon. And then from the standpoint here, Pennsylvania will ultimately, if the governor goes Republican, will ultimately turn most likely, even more restrictive and maroon. So a lot of things are in play and are certainly, concerning. But this is a map of where we exist right now. And certainly, I think you can take the map down, and I'm going to go over some of the statistics a little bit that are associated with this. So in those 15 states that you saw that were maroon and sort of dark orange, ultimately, they accounted for 125,000 abortions in 2020, and Georgia accounted for 41,000 more abortions in 2020. So right now, based on the 2020 data, you have about 160,000 abortions or patients ultimately who now live in states that either have significant bans or bans at 6 weeks. So you now have 167,000 patients that are ultimately now in a situation that are not able to find care in their state. And that number could only get worse as those sort of dark orange states ultimately, or lighter orange states ultimately turn into dark orange or maroon based on the map. And in those 15 states, they are home to almost 22 million of reproductive age between the ages of 15 and 49. And other data that we found from another study from the Society of Family Planning called the We Count survey, in the states that had bans and restrictions in those dark orange and in those maroon states, there were about 22,000 fewer abortions in July and August in the months after Roe was overturned. And what they found is in the blue states that there was an increase of ultimately 12,000 abortions in the blue states. So what that suggests and tells you is that ultimately 10,000 patients, ultimately 12,000 were able to find their way to blue states, and 10,000 patients were ultimately not able to find their ways to protective states to get an abortion. And what that ultimately suggests is either those 10,000 patients either ultimately continued their pregnancies or ultimately ended up trying to figure out how to have an abortion through other means. So ultimately, again, it really puts a significant concern on what is going on here. And we know also from, the data that, banning abortion doesn't ultimately decrease abortion. It ultimately leads to unsafe abortion, and ultimately only increases maternal morbidity and mortality. So just on a few of the other numbers, what we see in our blue states is the biggest states that are seeing increases are Illinois, North Carolina, and Colorado. And what we're seeing here in New York, as I'm going to transition into sort of New York and Mount Sinai, is New York is seeing an increase of 12% of cases since Roe has been overturned. So what I want to ultimately sort of do here is sort of move a little bit to what I'm seeing here at Mount Sinai. And what we are seeing at Mount Sinai is a reflection of those numbers. We are seeing an increase of out-of-state abortion seekers. Many of these cases are high risk that need hospital care. And in the last few months, we've seen approximately 1 to 2 cases from out of state. And this includes patients from Georgia, Florida, Texas, Ohio, and South Carolina. Some of these patients have required financial assistance, and through the Mount Sinai Care Fund, we have been able to cover the care costs for those patients. And again, many of those patients are uninsured, underinsured, or some of those patients actually have commercial insurance. And because they have to travel state to state, they lose their insurance when they travel from one state to the other, which is, I mean, again, a situation where they are in desperate need. Just to give a little bit of background of the Mount Sinai Care Fund, which Dr. Stone spoke about, it was developed in April of 2022. It became clear that the hospital-based care and expansion of services was going to be a vital component. And again, many women who are at high-risk cases need hospital-based care, and Mount Sinai is uniquely prepared to support those patients in that system. We have all of the necessary coverage from other services, hematology, cardiology, anesthesia, and we do have ICUs and a labor floor for patients who need a labor induction. So we are uniquely prepared to take care of high-risk cases. We did begin the Care Fund in 2022, and since that time, just within the first month of setting it up, we've been providing care through the Care Fund for one patient per week. And again, these are patients from Georgia, Florida, and Texas who clearly need financial support to come to Mount Sinai to receive help. And with philanthropic assistance, we anticipate we will be able to cover the cost for approximately 50 patients per year to get care here at Mount Sinai. So what we have seen right now is, again, and I know it's frustrating for so many people to see what's going on here. It's both sort of horrifying to hear these stories, but it's also what you're seeing is the community coming together and is extremely inspiring. Patients and organizations are coming together, and we're figuring out how to work this problem in this situation to provide essential health care to patients that need it. And our partnerships with national organizations like Bridget Alliance, Planned Parenthood, Haven Coalition, these organizations that pay for travel and housing costs work with us, and we take care of the procedure costs, and ultimately we work together to figure these out. So it's really inspiring to see this unbelievable collaboration occurring between academic centers and organizations to get patients the care they need. And I just want to take a little bit of time here to go over a few of the stories and cases that I have, been able to be involved with. In a recent case from a patient from Florida with a significant medical history, she received an abortion at Mount Sinai. She traveled to New York for 4 days, and through an amazing collaboration received a safe abortion. The collaboration included Mount Sinai providing the Care Fund, Planned Parenthood providing assistance for travel costs, and a volunteer at Haven Coalition providing housing for 4 days. It was absolutely an amazing collaboration. The patient went back to Florida after a safe abortion. In another case, a patient with a lethal fetal anomaly and severe medical condition traveled from Texas. She stayed in New Jersey for 2 days, and she stayed in New Jersey for 2 weeks until she was medically stable. The entire time she was separated from her husband and 2 children, and we couldn't even get her medical records because the providers in Texas were so fearful of the SB 8 civil law to provide us of her records that they would be involved in her case. After the procedure, she went home and had a safe procedure here at Mount Sinai, and then ultimately at that point was so grateful and returned to her loving family in Texas. And one other case I'm going to just discuss, a patient from Ohio who was sexually assaulted, came to New York. Her abuser is currently in jail in Ohio. She was forced to travel to New York for her care, had a safe abortion here at Mount Sinai, is not returning to Ohio at this point except for the criminal trial, and is going to stay in New York from now on. So I want to stop there, and just sort of say, I want to, provide people, I know those stories were tough. I want to provide people with some hope and some inspiration. I have been so moved and proud of how many people have responded to this decision, and everyone on this webinar and anyone who's getting involved needs to be congratulating to be wanting to be a part of this. I've had the privilege and honor of taking care of these patients and seeing them go back to where their homes are in their states. And I'm so proud of the work of helping them and the work of the Complex Family Planning Division. And it's really been a team effort, and it's just been uplifting to date. So again, Alexis, that was an easy question for me to answer because I just felt so honored to take care of these patients and to give everybody an update of what's going on. So thank you.
Thank you, Dr. Jacobs. Honestly, every time I hear you review that interactive map and talk about your patients, I can feel how real and imminent the effect of the overturning of Roe v. Wade has been on patient care. And I want to thank you and Dr. Stone and Dr. Dragoman and all of your colleagues for caring for this influx of patients with so much compassion. As I can imagine, like, it's just such an emotional moment in their lives, and thinking about them being far from home and in a new place and with people that they don't recognize. Like, they're really lucky to have caretakers like you guys. And yeah, I'll leave it at that. Your patients are very lucky to have you.
Thank you.
So in-person care is not the only change that we're seeing. Dr. Dragoman, how have telehealth services changed recently?
So let me address a little bit of that. I think we have to go back a little bit and appreciate that it all starts with decades of work to develop and refine a variety of options, medical options for abortion and medical management of pregnancy loss. So mifepristone and misoprostol, the medicines we use in combination for this process, are truly the revolutionary reproductive health technologies of our time. There is just decades of accumulated and abundant evidence that demonstrates that early medical abortion is safe and effective when quality medicines are available, and accurate information are provided. Medications are used according to evidence-based guidelines, and systems are in place to recognize and manage the very uncommon complications that can coexist with navigating this process if necessary. And truly, if there is one silver lining of the COVID-19 pandemic, I think it is that it compelled development of a lot more simplified protocols and fewer requirements for routine exams, tests, or diagnostic imaging to safely offer early medical abortion without an in-person visit for folks who have otherwise uncomplicated care. And truly, through the intersection of circumstance, the dedicated work of clinician researchers and advocates, we've been able to really streamline and advance the protocols and possibilities for folks in need of medical abortion, both across restrictive and less restrictive environments. What does that have to do with what we're doing here at Mount Sinai? Well, we have certainly for several years been offering medical abortion via telemedicine to navigate various aspects of that process. However, I will say that we are very much looking forward to piloting a no or low touch direct-to-consumer telehealth medical abortion model in 2023, which is an exciting development for our team and for our patients across the health system. And effectively what that means is patients will be able to communicate with a trusted physician when they're looking for medication abortion, and be able to consult for care and also receive their medication at home to initiate their procedure with that in the privacy and convenience of their own house. Currently, we're going to be structuring that for patients within the Mount Sinai system and who are also residents of New York State.
Okay, thank you. And still on you, Dr. Dragoman. In our February webinar, you shared a heart-wrenching story about a patient of yours from Texas. And I understand that another patient has graciously shared their story with you. Would you be willing to read it to us?
Alexis, the truth is, I think we all can talk all about the importance of the care that we're providing and what it means for patients. But there really just is no substitute for hearing a personal account of what it takes to access essential healthcare in these times that we're living in right now. What I am going to read comes from a recent patient and her partner who traveled from Georgia to Mount Sinai for an abortion when they learned that their pregnancy was complicated by a fetal anomaly. We have permission to share her story, but I also paraphrase a little bit of the testimony for time. So she wrote, "My husband and I both come from families of messy divorces and have dreamed of nothing more than having our own family, our own children. We were married in December of 2021, and in April of 2022, the pregnancy test turned positive. We couldn't wait to share the news. There was so much to look forward to, and we were so excited. At 20 weeks, our amniocentesis results showed we were having a son, but he had a chromosomal deletion. We researched what this could mean as we waited to do a fetal MRI. Test more imaging. The day of our MRI, the doctor showed us the images and highlighted that our son was missing half of his brain and had no nose or bony structure in his face. He would not survive outside the womb, and we needed to make a difficult decision to have a termination or give birth and know he would die in our arms shortly thereafter. I distinctly remember saying, "But we live in Georgia." And the response being, "Yes, I'll text you the National Abortion Hotline number, but that's all I can do from a resource perspective." We had 3 Georgia providers promise to call or email us with resources that never came. I called 18 locations across New York and Connecticut, knowing that we had at most 2 weeks before the decision was made for us to carry to term and watch our first child die in pain. Then I called Mount Sinai, and they helped us. They helped us show our son mercy and never having to experience the full pain of his condition. One heart-wrenching story about that reflect the real life experiences of patients who are dealing with the harsh realities of the restrictive landscape in real time. And I did want to also highlight before moving on that we, just to share some information about an additional resource we have at Mount Sinai that is a real centerpiece and resource for patients in this circumstance, our Mount Sinai Perinatal Bereavement Program. This program is designed for women and families who may be struggling with fetal abnormalities, difficult pregnancies, and fetal loss, and can offer individual or complex, individuals or couples counseling, support groups, and memorial services. And it's been a very special resource at our institution for years, and even more important as we're seeing patients in these dire circumstances show up on our doorstep for care. So actually now, Alexis, we're going to put you in the hot seat. I'd actually like to ask you a question. So as a former chapter president of Medical Students for Choice at the Icahn School of Medicine at Mount Sinai, you yourself were involved in really important advocacy for curriculum changes to further incorporate complex family planning and reproductive health topics. Sharing how inspired you are to be with us, I have to say it goes for us as well to be so inspired by being able to be working with you, and the bright, shining spirit and intense intellectual ability and your passion really makes the work that we do mean that much more, because we see that you're going to be carrying the torch for us when we're gone. So can you just step into describing a little bit more about what you yourself are doing and your peers to step up and ensure access to abortion care and medical education?
Of course. Thank you so much for all those kind words. It's seriously an honor to be here. But yeah, so I became chapter president of Medical Students for Choice during the end of my first year as a medical student. And pretty much immediately upon taking over the role, the Texas SB 8 decision was made. So I did what any first year medical student would do, and I turned to my faculty advisor, Dr. Adam Jacobs, and said, what should we do? Like, we have to do something. So what do we do to make sure that Mount Sinai continues to be a place that prioritizes equal and compassionate and evidence-based care, despite kind of all of this legal stuff that really did not make any sense to me as a first year medical student. So in direct response to SB 8, he helped me draft a statement that was sent out to all students and House staff announcing Sinai's opposition to the bill and any similar bills that followed. We also hosted a talk with one of our physicians at Sinai, who's also a lawyer, who helped kind of explain what this legislature meant and kind of anticipate what was going to come next. And as you all know, similar bills did follow, and Roe was overturned also during kind of this time that I was with Med Students for Choice. And we just used it as a further call to action. We worked with the dean of the medical school to draft another statement in opposition, and immediately organized a group of Sinai students to attend rallies throughout the city. And backed by the support of the Division of Complex Family Planning, we formed a coalition with other medical students from across the New York City and greater New York area to promote abortion education and abortion access. And I'd like to mention that many of these medical students from non-Sinai schools have since joined my unofficial fan club of Dr. Jacobs. And together we hosted virtual and tabling fundraisers, which raised over $20,000 for the Bridget Alliance and the National Network of Abortion Funds. We also wrote and edited a resource guide entitled Accessing Abortion in New York City, a guide for medical students by medical students, which will be published online through the library with the goal of filling the medical school curricular gaps and generating momentum for more education reform. And lastly, with the help of Dr. Dragoman and Dr. Jacobs, we were actually able to create a brand new course for Sinai medical students and graduate students. It's a 6-lecture series, which we're actually, I think tomorrow's lecture 3 of 6, where different faculty members from the Division of Complex Family Planning come and give an hour-long lecture on a different topic in abortion, kind of ranging from the clinical and public health perspectives. And they share information about innovations in access and review the regulatory landscape and its implications, all kind of within the context of ethical considerations and value clarification. So we've been doing our best to keep our med school and our students kind of up to date on how to provide compassionate and evidence-based care. And all of my crazy ideas definitely could not come true without your support and your help. So I'm really proud of the work that we've done. And yeah, so that's that. And with that, I think we'll transition to Q&A. But first, I'd like to thank Dr. Stone, Dragoman, and Jacobs for being such amazing role models for all of us medical students on how to advocate for reproductive rights and how to really create change during a time where it feels like it's really hard to make change. And I want to thank you guys for sharing your insights. And with that, let's get started on some of the questions. So let me see. I think any of you can answer these, but any suggestions for non-OBGYN physicians who are interested in becoming more involved in abortion care? Is it worth getting trained to perform a first trimester procedure? And is there a need or role for non-OB providers?
Take that one. I think in terms of developing a workforce for non-OBGYN providers, I will say that we all have a role to play in terms of trying to figure out how to support access for folks in this crisis. Given what Dr. Jacobs also shared, there are a lot of folks who have the requisite expertise and who've dedicated their professional lives and careers to training in this area. And we actually have a surplus of providers in it to a certain extent, while we have, a surge in demand in other places. I would say in the moment, probably the best thing that folks who are non-OBGYN physicians, the best way to function as a support is really as an ally to help advocate within your institution to make sure that services are available, folks are practicing to the full extent of the law, helping to support through donation and fundraising to ensure that services can be provided to the greatest extent. I think that in terms of training, we have a tremendous unmet need for training in general and a finite amount of faculty and teams who are available to provide that training. So trying to figure out those mechanisms and prioritize amongst the many numbers of trainees that have that need is a challenge. So I would say that probably there are other ways to be able to contribute and prioritize first.
Okay. Next question. Patients are increasingly concerned about the role of data privacy and the role that plays in abortion access, especially given the increase in news articles on data privacy and searching for abortion services online. How does this impact New York abortion providers, and how do we counsel patients both in and out of state?
Sorry. Hi, sorry about that. I was having problems with my computer. So I know it's a concern for patients from the standpoint of data privacy. Obviously, Mount Sinai adheres to all of the encryption and data privacy that we can provide for our patients. Certainly, I know there's a concern of where you're using sort of online services and is anybody getting into that data or data privacy. But we know through our partners here at Mount Sinai that if patients are coming here, their data will be protected through the same aspects that we protect all the patient privacy and information through Mount Sinai Medical Center. So it is an ongoing issue. And certainly if we start to go to sort of, the sort of medical abortion services and the online services, we will make sure that we protect their privacy and their data as well as we do for any other patient at Mount Sinai.
Okay, great. I was actually really curious to answer that question myself. So that's really comforting to hear. Okay, next question is, could you please speak to the impact of the Dobbs decision and future legislative changes as a result of today's election on OBGYN training programs, and how is ICON responding?
I'm happy to take that one. Well, I will say it has put the entire state of training into a place of tremendous chaos. Back in the mid-90s, the ACGME actually made training in abortion and reproductive health services an accreditation requirement for all OBGYN residencies. And now programs in places where those services are no longer able to be provided are scrambling to try to figure out appropriate solutions to ensure that their trainees have access to appropriate education and training to be able to fulfill their professional requirements and training requirements. I will say that there are a lot of exciting and creative possibilities that are, on the table, and we certainly at Mount Sinai are exploring what possibilities exist for us to open up opportunities for training to external rotators who are interested in this, both as a one-off opportunity for folks who are looking for this training, as well as potential formal partnerships with particular institutions, while also ensuring that our current commitment to train 17 residents per year from our Mount Sinai West and Mount Sinai Hospital residency training programs, as well as our two fellows each year, have access to sufficient training, and we're able to fulfill the commitments that we have to provide them with the highest quality evidence-based training as well. So certainly it's a delicate dance. We are expanding our faculty and also footprint across the health system, which will help us both meet our patient care demands as well as expand possibilities for training. So it is a core value for all of us and something we're really committed to expanding.
Yeah, and Alexis, if I can answer that too, just for a minute. I know that's, I agree with Monica on that answer. We are desperate to look at how we can expand the services with the 17 residents that we're training right now a year. And we're going to work on that to see what we can do. We are also dedicated, and we are taking numerous medical students who want to come, third year, fourth year students through electives. So we've opened that up, and I am taking, monthly, students from all over the country. So we are expanding our medical student electives. We also have a medical student doula training program. We have numerous things that we are expanding through the medical school and through the country on the medical school end. And I'm pretty comfortable to say that at some point, I think we're going to try to figure out somewhere down the road how we can absolutely, get involved in the training program. And Dr. Dragoman, I think, really hit it. We just need to sort of see how things play out over time to get to that point. But we really are expanding education nationally through the medical schools, medical student for choice, electives, and other opportunities from that standpoint.
Yeah, and also speaking on the electives, Dr. Jacobs and Dr. Dragoman's family planning elective is a very popular elective among medical students, and we are very grateful that they opened it up to more students, because You just get to learn so much. And in addition, you guys also helped run our OBGYN clinical skills night last week, where students also learned some hands-on skills about pelvic exams and birth control, which went really well. And our first and second years always love that night. It's really fun. So thank you guys for answering that question. And next question, kind of on the same topic of training and having more people around. How's Mount Sinai involving its many great midwives in their efforts to expand access to abortion and contraception?
So maybe one of the things we're really excited about in terms of initiatives to really expand access to abortion services across Mount Sinai is strengthening our already great relationship and partnership with labor and delivery for the care that we're providing, especially for folks who are finding that they are navigating very severe maternal or fetal conditions requiring an abortion or pregnancy management as pregnancy advances. When they request potentially an induction procedure which is occurring on our labor and delivery. We have a robust midwifery service, and we're looking forward and actively planning activities for us to strengthen some of our culture and skill set and support for patients finding themselves in those circumstances and really targeting the entire team for a lot of those activities. Special and important service that we are well poised and have been leading at Mount Sinai for a very, very long time, especially in collaboration with our maternal fetal medicine colleagues and the ongoing leadership from Dr. Stone.
Yeah, I'll just jump in for 1 second to add to that. I think that the maternal fetal medicine division, which is my specialty, works very, very closely with complex family planning and taking care of some of these patients, because these patients are, with fetal anomalies, for example, that are very far along. We have to stop the heartbeat in some cases before they deliver, so that not delivering a live born child with major anomalies. And I think that one of the things that is so special about the care that's received in the labor floor, we also have run a special clinic for patients who've had a stillbirth in the past, and the sensitivity involved with taking care of those patients, as well as patients who are undergoing a termination on the labor floor, is incredible. I mean, the nursing staff, the people that greet the patients, the midwives, the PAs, the residents are incredibly compassionate in the way that they take care of these patients. So it's really a testament to our coworkers on the labor floor who provide such incredible care for these patients. So I'm glad that question came through, and Monica, you brought up that point about how midwives can get involved. And I also think, we're looking at doulas, and we have also, it was mentioned before, the perinatal bereavement program, because these patients, they need that social work support after too. I mean, after undergoing this procedure, they struggle so much just to get here and get the sorely needed procedure that they've had, but yet, there's that other component of feeling that tremendous loss. So I think that that follow-up care that they receive has been incredible. And I've seen many, many letters that written to Dr. Dragoman, Dr. Jacobs, and their colleagues about the incredible care they've received and how grateful they are, and they really follow up with them after. So I think it's a really important partnership.
Yeah, and I have to agree with both Dr. Dragoman and Dr. Stone said. I've had the opportunity of working with some of the midwives on the labor floor, and they are key partners in this situation. We have patients that the only option for the termination of pregnancy, or maybe the patient's choice, is a situation where a labor induction is going to occur. And in many opportunities, with issues with a lethal fetal anomaly, maternal health, other issues, and these are extremely, extremely sensitive cases. These are extremely difficult cases, and we've worked with the midwives in the aspect of helping with these cases through the induction, through the delivery, through the aspects of, I mean, working with the patient on providing the most, I want to say, comprehensive amount of care, from the aspects of wanting to possibly, hold the pregnancy, to wanting to, for footprints, for, any sort of, memories that will help this situation for the patient, for the couple, for the family to get through. So we've worked seamlessly with the midwives, and I think that role on labor and delivery is an amazing thing that they help us with. So yes, I do agree with Monica on that aspect, and I only see that being something as the more difficult cases come here, that ultimately labor and delivery is going to be a key component to this, and certainly so will the midwives for those cases.
Yeah, thank you guys for those amazing answers. I mean, what I always think about is like, if I ever was in that type of situation, you were the doctors that I would want for me or for someone that I loved, a family member, a friend. So people are really lucky to have the care that they get at Mount Sinai, and it's really amazing. Okay, so next question is, can you touch on miscarriage in a post-Roe v. Wade world?
Well, I'll just I was just going to say just briefly, and then I think Monica or Adam will probably take over the discussion, but it's very concerning and controversial in certain areas. So there's a lot of discussions about, for example, certain pregnancies that are not viable. So for example, you can have a pregnancy that is implanted into somebody's prior cesarean section scar that has very, very dangerous implications for the patient, and it's really not viable and but there might still be a heartbeat there. And so there's a lot of concerns about how to care for these patients who need really immediate attention, or for example, an ectopic pregnancy, where the pregnancy might be located in a tube, it's not viable, and they need to get emergency care, or somebody that may have broken their water early, there's still a heartbeat, and that patient's at risk for severe infection and sepsis and needs immediate care. And I can tell you, I talk to my colleagues in these restricted states, and they can barely counsel their patients. I mean, everything is a concern for, what they can say, and in certain states like Texas, criminalization, and it's really heart-wrenching. I think that there are certain areas that are gray for the physicians in these states that are taking care of them, and they have to get advice from the hospital legal team. What do they do under these circumstances? So I think we'll see more about this, but it's a truly area of great concern, especially when it impacts on a woman's health risks.
I was going to just also add, reflecting on our own landscape of practice, we are the primary providers of abortion care, and also our complex family planning team are also the primary providers of our pregnancy loss management in the first and second trimester. And I'd say that the proportion with which we're taking care of these patients is probably about a 50-50 split. And as we're seeing changes in demand for abortion services, I'm so proud to share that it's not having an impact on our ability to care for and meet the needs for the needs for timely care for patients facing these other types of pregnancy crises. I think that in general, we have an incredible system and support structure of infrastructure to make sure that all patients facing different challenges with early pregnancy requiring our care are able to access it in a timely and everything is urgent in this domain for management. for all of our patients.
Yeah, and I just want to add one point to this. It is a scary moment, and I know Joanne talked about it with other colleagues. I mean, I got a call recently, just last week, of a patient who was in Florida, and they really were struggling on how to handle a situation on their labor floor, and they, were trying to get the patient to New York, and then I basically had to get them in touch with, people with the, ACLU who could help them work with their legal team. It really became something scary. And even after all of that, the patient really didn't even want to ultimately, stay in that state in Florida. But because she was so sick, she had to, stay there. But it really is getting scary for our colleagues. They don't know, in many cases, how to interpret some of these things, and it's a moving target. So we're doing the best we can to support them and make sure that we ultimately, can give them as much advice so that we can.
Well, I am going to go ahead and close. Where did this hour go? I feel like time has just marched right on. It's been an incredibly rich and engaging session, certainly for me as a participant, and I hope for everyone else. I really want to just thank Susan, Joanne, Adam, and Alexis, everyone for their thoughtful insights on one of the most urgent healthcare crises in the United States today. In the past several months, my colleagues and I have seen patients and families in crisis, traveling great distances and finding themselves separated from their communities of support, all in service to access basic and essential health services. I have to say, I am incredibly proud, as well as my colleagues are as well, to care for any patient that's able to make their way to our doorstep. And we are also incredibly grateful to you, our guests, who joined us this evening. We've had some really great questions, and I hope that we've answered them to your satisfaction. And if you think of anything else, we'll be able to connect and respond after this session's completed. As a follow-up to tonight's webinar, we will be sending you a recording along with some ways to support the Division of Complex Family Planning. And as we discussed, the Philanthropic Care Fund is removing the financial burden for women unable to cover their medical expenses who are coming to Mount Sinai amidst a myriad of obstacles. Please know that any gifts, a gift of any amount, really can make a meaningful difference to the women and families that we serve. Really want to thank you again for joining us in this incredible evening and discussion. Please be well.